Morning. Thanks everybody for coming today. And Pat, thanks for inviting us. I'm actually pinch hitting as well. Giselle Scholler, who is actually our PI for the entire consortium, couldn't make it today, so I'm the backup. I'm going to talk about a number of trials that we have open, one that just closed, and some trials that will be opening in place of this one. So I have a fair amount to talk about today. I'm going to talk about trials relating to 3 different experimental drugs, and then finally I'm going to talk about our just opening trial for personalized medicine. Upcoming trials I'll mention as well. I actually added the slide, which is not in your handout, yesterday. After listening to a lot of the talks yesterday, one of the things I talk to parents about when they first come or talk to us about wanting to be on trials is what the different trials mean. And I thought a very brief overview might be helpful. So as you notice, I've got phase 1, phase 2, phase 3/4 trials, but an arrow going in the opposite direction. The reason I did this is actually the direction in which treatment really occurs. When patients are first diagnosed, they're offered standardized therapies. Although they may be trials, it's things that are actually in place already, things we know a lot about. We have a lot of information, and so those are our standard therapies. That's where initial therapies go through. If patients relapse, however, that's when experimental therapies start coming into play more. Phase 2 trials are ones in which there is already some information about the drug or treatment that you're using, and in the setting of trying to understand how a particular tumor may be responding to that particular drug. And also trying to get some safety information. A phase 1 trial is the earliest trial when a drug is brand new. Not a lot will be known about the drug. There may only be lab data so far, animal and tissue culture information about it. And so the trial itself is actually set up as a safety trial. That's required by the FDA. So when we talk about different trials, it's important to know what you're asking about or what you're being asked to participate in. So I'm going to start first with a drug called nifurtimox. We've had a phase 1 trial that's actually finished and a phase 2 that's actually ongoing. This is an interesting drug. This was found by accident. This drug is actually used to treat a parasitic infection called Chagas disease, which is found primarily in Central and South America. It also is used to treat African sleeping sickness. This drug, nifurtimox, was developed in the 70s as a means of treating these basically worm infections. A patient actually contracted this disease from a blood transfusion who was being treated for neuroblastoma. At the time of contracting it, the patient was not doing so well, and once getting nifurtimox added to the therapy in order to treat the Chagas disease, actually improved as far as how well the tumors were responding. So Dr. Scholler, who was the primary oncologist at the time, had a lab going, and she said, something's going on here. I need to take this to the lab and find out what goes on here. So she did some background studies in tissue culture and animal studies and found that there was an effect both by the drug itself as well as in combination with some of the standard drugs we use for treating neuroblastoma. She then took it forward to a phase 1 study. Its mechanism of action, what she found out, is it increases free radicals through redox or oxidation mechanisms. Free radicals within the cell tend to damage the cell wall as well as the DNA of cells. Many of our chemotherapy drugs work this way, as does radiation therapy. So it was a mechanism of action that seemed useful for neuroblastoma cells. Turns out it also gets taken up in very large amounts in cells that are producing catecholamines, which neuroblastoma cells do. So there was a biologic reason why it might be working in neuroblastoma cells. So based off of the preclinical data of several cell lines showing increasing doses of nifurtimox having effects on cells, it was taken into a phase 1 study. The phase 1 study, as I said before, its primary goal had to be safety as well as understanding the toxicity. So how much can you actually give someone? Most phase 1 studies are set up so that you enroll a few number of patients at a time, in this case a few children with neuroblastoma, see how well they're doing as far as from a safety standpoint, and as long as they're not having significant bad side effects, increase the dose for the next group of children, and so on until you reach a point where there's too much trouble from the drug. Because this drug is used for a different clinical reason, there was at least a starting point for this particular drug, although they started 2 dose levels below the current recommended dose for treating patients with Chagas disease. And they were able to increase basically to the dose that's actually used now for treating Chagas' disease, and found that there were significant problems. The drug itself and secondary gains, of course, are whether it will actually improve outcome for patients with neuroblastoma. Our phase 1 studies have all been designed a little different than most phase 1 studies. The average phase 1 study uses a single treatment, a single drug that you're trying to identify whether it is safe or not, and then secondary gains whether it has any benefit. All of our phase 1 studies we've set up such that there will be an open window for the drug itself so that we can satisfy the FDA as far as getting safety information on the drug alone, but then we add in additional chemotherapy agents that are known to be effective against neuroblastoma, either by themselves or in combination. So this particular study, nifurtimox was added to topotecan and Cytoxan, which is a common secondary treatment for relapsed neuroblastoma. And in the laboratory, it was shown that both nifurtimox alone and in combination with these two drugs increased drugs. Yes, sir. Oh, too soft? Sorry. Is that better? Ah, I'm getting an echo, so that's why I thought it was fine. Oh, sorry. So we added topotecan and Cytoxan to this trial as well in order to add benefit to the potential outcomes. We evaluated pharmacokinetics or PK studies in order to find out how long the drug is staying in the person's system itself. Nifurtimox was actually given as a continuous medication. So it's a pill form medicine that's given. You take it 3 times per day. It's taken orally for the entire 21 days of a cycle. The first cycle was by itself. Subsequent cycles were given with Cytoxan and topotecan. Various dose levels were tried. The dose actually at 40 milligrams per meter squared turned out to have significant problems, and the dose at 30 milligrams per meter squared was where the maximum tolerated dose was determined to be safe. Where patients ended up having issues, the dose-limiting toxicities were primarily what was noted already from studies using it in treating Chagas disease, which it has a significant effect on the nervous system itself, both peripheral nervous system and central nervous system. So peripheral neuropathies, feeling like your fingers are asleep, your toes are asleep, stumbling for little kids sometimes an issue. The dose-limiting toxicities, however, were seizure and one patient who had hemorrhagic cystitis. The seizures were all reversible with lowering the dose of the drug and starting anti-seizure medications. So the response data, there were 14 patients who were evaluable for response. Nifurtimox was given alone in all of those patients, so we were able to see that even with nifurtimox alone, that at least 6 of the patients showed stable disease while taking the drug alone. 10 of the patients were evaluable response for at least 3 cycles, meaning that they got topotecan and Cytoxan added to it. Of those, 3 had partial responses, 5 had stable disease, and the mean time to progression-free survival was 7 months. So there seemed to be some benefit for this, and realized these are all in children who have had multiple previous therapies. So this was then moved into a phase 2 study. The phase 2 study objectives were now to find out not only safety, but how effective would it be in children with neuroblastoma. We added also medulloblastoma, which is a brain tumor. In the lab, this was shown to have benefits by adding nifurtimox to topotecan and Cytoxan, and so in order to offer it to more children, that particular tumor was added as well. Initially, there were 21-day cycles. The first 2 cycles were drug alone. This was actually a request of the FDA in order for us to try to move this drug forward. They wanted more pharmacokinetic data, so we started this trial with just drug alone initially, and then added topotecan and Cytoxan, given as IV medicines for 5 days each 21-day cycle. Here's a couple of pictures of patients who were on the initial study. This is after just the 6 weeks of topotecan alone. This is a patient who has neuroblastoma, but actually in their spinal cord. You can see that there were changes on MRI scans of some of the tumors that actually have made them smaller. On MIBG scan, a patient who had significant bony disease as well as a liver metastasis had significant change, again, just with nifurtimox alone. However, we were seeing more of the children on a 6-week cycle not being able to have significant benefit of nifurtimox alone, so we amended the trial after we were able to collect enough data for the FDA And now all children on this trial receive nifurtimox, topotecan, and Cytoxan at the beginning of the trial. It's currently ongoing. The effect of nifurtimox alone, historical response is going to be compared to historical response of topotecan and Cytoxan, which was a previous phase 2 study, and in that study there was a roughly 32% response rate. So I don't have final data because this is actually still an ongoing study. So the next trial I'm going to talk about is TPI 287. This is a drug that doesn't even have a real name yet. We have a phase 1 trial which just closed to enroll the last patients last month, and a phase 2 trials which will be opening sometime this fall. TPI 287 is a member of the taxane family. The ones that most people have heard of are docetaxel and paclitaxel. They are microtubule inhibitors, but they work different than most of the other microtubule inhibitors that are on the market. They actually stabilize microtubules, don't allow them to fall apart again. Modifications to the native taxanes were made in order to design this drug. Changes were made to the side chain, which makes it easier to get inside of cells, and then modifications to its ring structure were made in order to make it more resistant, more helpful in patients who have MRD resistance. MRD resistance or multi-drug resistance capabilities are common in a lot of tumors, and especially in neuroblastoma cells. It also allowed for better binding to tubulins that might be mutated. So normal taxane structure, which is paclitaxel, there were two different portions of it, a side chain and a ring structure, and both of these were changed in order to benefit the drug. The normal taxanes are not effective against neuroblastoma. They've been tried in studies back in the 90s. They really were not very helpful. This particular drug, though, by itself and in combination with temozolomide, was shown to be effective both in cells that are not MRD positive and those that do have multi-drug resistance abilities, and found that combination therapy was quite effective in reducing therapies. So after preclinical studies, a phase 1 study was tried. Here in mouse studies looking at how tumors grow, none of the other taxanes had any significant effect against growing tumors, whereas TPI 287 alone did. So the phase 1 trial, which was to use the drug alone initially for the first cycle, and then after that adding temozolomide to the trial in order to increase the chance of response. So the study itself, objectives again, the first objective has to be safety, understanding how safe the drug is. Secondary objectives were to find out how active it would be by itself, as well as in combination with temozolomide, looking at overall response and progression-free survival. We also wanted to evaluate the pharmacokinetics or PK of the drug itself and in combination with another drug, temozolomide. And then we wanted to also study both tumor cells from patients in the lab. So patients who agreed to have bone marrow samples collected, those samples were actually tested in the lab for both this drug as well as others. The phase 1 study design, as before the first 2 cycles, were drug alone. The drug is given as an IV drug once a day per week for 3 weeks in a row of a 28-day cycle. Following this, then cycles 3 through 6, temozolomide was added. Temozolomide, as most of you know, is a pill or can be compounded into a liquid. Children take that at home once a day for the first 5 days of each cycle. And then plasma samples were sent for patients as well. The dose level, 3 patients at each dose level initially. We started at 20% of what the adult maximum dose was from 2 previous phase 1 studies, and increased from there. We got to 135 milligrams per meter squared, which is slightly above the adult dose, maximum tolerated dose, and found that we were having some problems, so we backed down to a slightly lower dose, and then found that the 125 milligrams per meter squared was the actual dose that could be tolerated well by most children. The combination therapy did not add any significant problems once we got to cycles 3 through 6. So the safety data from the trial showed that we had 1 dose-limiting toxicity at 110. It was a patient who had a seizure, thought that it could be related. At 135 milligrams per meter squared, there was 1 patient with a grade 3 neuropathy, as well as 1 patient who had hematuria, which was not present at diagnosis. So we ended up with 15 patients have been on trial so far and gone all the way through the first 2 cycles in order to have safety data. And then the maximum tolerated dose, as I said, was found to be 125 milligrams per meter squared. So far, we have 11 patients who are actually evaluable. There are still children on this trial receiving the drug, so we don't have all data on all 15 patients yet. But 11 of them have been evaluable for response. 7 of the 11 had stable disease for more than at least 2 cycles. 5 of the 9 who entered the study who were having progressive disease at the time that they started the cycle also had at least stable disease. Progression-free survival in the study for all patients was 125 days. For those who had stable disease, these 7, their progression-free survival was 177, and we had 1 patient who was on the trial for a year. Those who had progressive disease within the first 2 cycles, their progression-free survival was 34 days. So we have significant information now from the phase 1 study. We feel that this is actually an active drug. We want to go forward with this into phase 2 studies. The TPI is actually being changed. The company is changing the formulation of the drug, so we actually have to do a small phase 1 portion of each of our trials in order to prove that the new formulation is going to be as effective. It's a drug that does not dissolve in water, so it has to be dissolved in something else. The biggest problem actually in the phase 1 study is that the drug was dissolved in something called cremophore, which is kind of toxic to the human body. People can get pretty bad allergic reactions to it. So the company's formulated a new formula of it that has a very low amount of cremophore but a higher dose of alcohol in it. The company tells us that the amount of alcohol per dose is about equal to a shot of whiskey. So the kids may be feeling pretty well after they get their dose. There is actually 2 phase 2 studies ongoing in adults with this new formulation, and they're not seeing significant problems. But we will plan to do a phase 1 portion of the study to ensure that it's actually still safe and move to the phase 2 study very quickly after 6 patients. Our plan is for 1 study for patients who have very refractory disease or multiple relapses to get drug alone. In this case, we're going to continue. The study will have a weekly dosing without a break. We'll have weekly dosing, so we're going to change from a 28-day cycle to a 21-day cycle. And because we did not feel that we had a significant benefit for the multiply relapsed patients in the phase 1 study adding temozolomide, we're just going to treat them with TPI so that we can decrease the side effects that come from adding temozolomide to the study. Patients will again be given it weekly, and they'll be at minimum of 6 cycles. If they're doing well, they can remain on it beyond the actual study period. Our phase 2 portion will be assessing efficacy of the trial. We want to find out how well the patients will do on this study. We're going to have 2 different strata. It's been shown in a number of studies that patients who have bone marrow and bony disease only seem to be different than those patients who have solid tumors. So we're breaking it into 2 different groups and plan to assess both strata as far as how effective it may be in these different patients. Our second study is a little bit more ambitious. The FDA, in order to try to get new drugs approved, really wants randomized trials to be performed. So we're going to attempt to do a randomized trial in this drug. This one will be for patients who are refractory to primary treatment or for those who've had only 1 or 2 previous treatments, so for early relapse disease. We plan to have randomization between irinotecan and temozolomide, which is now a standard combination for relapse patients, and comparing that to the addition of irinotecan, temozolomide, and TPI 287 to find out if we can in fact have an improvement by adding a 3rd drug to this combination. So there will again be a phase 1 portion. All the patients in the phase 1 portion will receive all 3 drugs initially. Following that, as long as there is significant safety and tolerability in this portion, we will move on to a phase 2 portion, which will be assessing both the efficacy and the difference between the 2 different arms. As I said, it will be a randomized trial. Arm A will be irinotecan temozolomide, and Arm B will be irinotecan temozolomide and TPI 287. For patients who are not receiving the TPI 287, if they have progression while on study, then they can move to Arm B and receive all the therapy on Arm B as long as they don't have a second progression. And for people who like to see it in a graph form, basically it's the exact same thing. Next, I'm going to talk about DFMO. We have a phase 1 trial with DFMO currently ongoing. As you've heard before, NMIC controls a lot of genes, and it's upregulated in many neuroblastoma tumor cells. One of the genes it actually affects is ornithine decarboxylase. Ornithine decarboxylase, turns out, is inhibited by this drug DFMO, and ornithine decarboxylase increases the amount of polyamines in the cell. I'll get to that in a second. DFMO decreases the polyamine pool. When polyamines are decreased, cells can't divide very well. So in neuroblastoma cells, both ODC and polyamines are markedly elevated in most of the neuroblastoma cells that have been tested. If you can decrease the polyamine pool, as I said, you can put cells in cell cycle arrest. That means they can't get into mitosis. If cells can't go into mitosis, then they're most of them will die off, especially if their trigger is to continue to grow and produce new cells. So our proposal was that by blocking ODC, you can actually cause cells to die off in neuroblastoma. Schematic form, there are actually 2 different pathways for producing polyamines. The primary one is this pathway. MICN actually upregulates this, so increases the number of polyamines, and on DFMO blocks this and can decrease it. So in vitro data, again, just to show you a little bit of it, without any drug, all the cells grow very well. Using a standard chemotherapy drug, TocaSite, you can decrease the amount of cells in several different cell lines. DFMO actually had a fairly close response to etoposide, and then when the 2 drugs are given together, there was a significant decrease in the amount of viable cells that were able to survive that combination. So a phase 1 study was started, which is actually ongoing. DFMO, first as a single agent so that we can get safety data on it, and then combining it with etoposide for patients who have refractory or relapsed neuroblastoma. DFMO is given just for the first cycle alone, which is a 21-day cycle. It's an oral drug. It comes as a powder. It can be mixed in a lot of different liquids. Most of the kids find it to be relatively palatable. It's a standard 3x3 design, which again, as I said before, you're starting with 3 patients at 1 dose and then increasing it over time. After the first cycle, etoposide is added, which is also an oral drug. So we're using etoposide orally, and they get etoposide once a day for the first 14 days out of a 21-day cycle. We are currently on dose level 2, and we'll soon enroll the last patient on this cycle. The combination therapy, as I said before, continues on, and this trial is actually currently ongoing. This drug is actually in limited supply, so there are only 3 centers that actually have this trial open currently. It's available in Grand Rapids, it's available in Orlando, and it's available at an affiliate site of ours for this particular trial, Children's Hospital of Orange County. Some of the early pre-studies were done at Orange County, and so they actually joined us on this trial. Now, that was a quick run through the chemotherapy drugs that we have currently. I'm going to spend hopefully a little bit more time trying to talk about personalized medicine. I know Dr. Mathey yesterday said that personalized medicine is in the future, but we are actually starting a trial as of this month. And so we are trying to do a personalized medicine trial. What does that actually mean? I'm going to go back to this picture that I showed you before. You have different phases of trials. This was really where you're trying to learn about particular drugs, whether in combination, possibly in combination, or about themselves and learning about safety. Personalized medicine trial is to actually set up a trial that learns from the patient's, in this case cancer, learning from the patient's own tumor cells what drugs might actually affect that cell and that particular cancer. So these are feasibility trials. So our hypothesis is that a genome-wide expression can be produced from a tumor cell from using microarray data and find out in a real time, meaning short amount of time, what drugs might be effective and come up with a treatment plan specifically targeted towards that patient. And the most important thing here is time. As many of you know, in children who relapse with neuroblastoma, this disease can get out of control very quickly. So finding some form of therapy in a relatively short period of time is very important. So the Human Genome Project, which completed in 2000, really set the stage for being able to do this. The Human Genome Project was designed to understand all the genes in the human body. Although it completed in 2000 and they had a nice little ceremony at the White House, we really are still learning a lot more about the human genome. This was the initial map. There are multiple variations of every gene, and we're still learning a lot of those. Some of those variations are things that lead to cancers. Some of them are variations that increase or decrease a person's susceptibility to particular drugs or therapies, and there's a vast knowledge out there right now that's actually very hard for any one person to understand. I'm going to give you just one example. This is ESR2 is a receptor that sits on the surface of many cells, including neuroblastoma cells. It's the estrogen receptor number 2, and these are all the drug targets associated with the estrogen receptor. This is called a molecular web or connectivity map. So you have one particular receptor on the surface of the cell. If it's activated, the green lines, which are a little hard to see, I know, in this picture, the green lines mean that something is being activated. The red lines mean something is being inhibited. So you have all of these various parts within the cell being affected by turning on one particular receptor. And the opposite is true. If you turn it off, if you can block it, then the green lines turn red and the red lines turn green. So it's kind of like a stop and go. All of this information, though, is a little too much for any one person to figure out by themselves. So there are now databases that incorporate all of this information for not just this one receptor, but thousands of receptors, as well as over 100,000 protein small molecule interactions, as well as the chemotherapy drugs that we use and what they affect. So with large databases of knowledge, we can actually now look at proteins, and in this case we're going to look at messenger RNA within cells and find out what actually changes. So our trial is a feasibility trial. As opposed to a phase trial, we're trying to find out how feasible is this. Can we actually do this? Feasibility trial using molecular guided therapy to treat patients with refractory or recurrent neuroblastoma. We started off with a pilot study. Our pilot study was, can we do this in real time? Can we biopsy a tumor, send it for analysis, have that analysis sent to the people who actually have the programs to assess the changes in messenger RNA, get it back to the physicians, have the physicians determine a treatment plan, make sure the treatment plan appears safe, and offer it to the patient and family. So that was actually our study. So we had to enroll patients, biopsy patients, produce messenger RNA, send that for analysis, get a report generated from that. A tumor board was actually held for every patient, which included a minimum of 3 physicians, and actually there were 5 on every single tumor board, as well as a specialist in understanding drugs, a PharmD, who understood pediatric cancers. This was then, after a tumor board determined a treatment plan, was sent to a medical monitor, someone unrelated to the trial, who would look at the treatment plan that was assessed and determine whether it appeared safe. Then it was presented to the families. We only used FDA-approved drugs, so there are no drugs listed in our treatments that are currently experimental. However, if targets appeared within the trial that were known targets of experimental therapies, those were also discussed with families. So our feasibility trial, as I said, tumors had to be biopsied, and they were sent to 3 different laboratory studies for analysis. Following that, bone marrow was also sent as a backup. Turns out that many of the samples from bone marrows are slightly different than the solid tumors that people have, and so we wanted to find out how much they correlated. But the actual tumor sample was what was used as far as the decision making. So feasibility, that was our primary goal. What could we do this? So we had 5 patients enrolled. There were 5 patients enrolled over 4 months. the amount of time it took to get each step was actually analyzed. So we had anywhere from a few days to get the actual DNA sent and put on a chip. The report was then generated through a computer system which analyzes all of the increases and decreases in messenger RNA compared to normal tissues. Then the tumor board was held within a short period of time, and then a medical monitor had to sign off of it. All of the patients, we were able to get a report and a plan together that could be given to families between 10 to 12 days. This is actually what one of the reports looks like for the physicians. So drugs are ranked. Over on this side, all these little blue squares are places on our computer screen when we see this that we can actually click on that will send us to the information, the evidence that tells us why that particular drug may be important. So we actually have the evidence at our fingertip when we go to look at these drugs as opposed to hunting through massive amounts of data to try to find it. So the report gives us all sorts of information. It tells us lines of evidence, where they actually got the information from. There are several different normal sets or comparative sets of messenger RNA that had to be used. In this, we were using messenger RNA based off of normal human tissue, primarily the adrenal gland. Also, we were using the messenger RNA samples from the NCI 60 tumor samples. It's a set of 60 tumors that are used for screening purposes when investigators are looking for whether new drugs may be effective. So we use that as well. We wanted to know whether there might be differences between different types of cancers, and if neuroblastoma cells had some increases or decreases between other cancer cells. That actually helped to narrow the window of therapeutic options by using those sets. So the report also gives us several other lines of evidence to tell us what may be beneficial, and again tells us why. The numbers that are listed here are what are called z-scores. It's a mathematical formula to give you an idea of how important something might be. So we could look at the different z-scores and tell whether something had a lot of evidence or whether it had a little bit of evidence. So back to our patients, as I said, we had 5 different patients who were enrolled on the study. One of the side parts of this was we wanted to find out, could we also set up in animal models in the lab samples from those patients and grow them in tissue culture or grow them in animals in order to also test the theoretical treatments that were produced from the samples. So of the 5 patients, we were able to get at least tissue cultures to grow for all 5 of them. Animal models were able to be pulled up out of 3 out of the 5, and we were able to pick out from flow data. That means we were able to isolate the cells from other cells that were in the samples to ensure that we had true tumor cells growing. So for validation purposes, patient tumor cells were grown so that we could actually test these cells in culture, and that's actually still ongoing. So the pilot study outcomes, we had 5 patients over 4 months. All 5 of them, we were able to get quality messenger RNA sent to the labs that were going to analyze the data. 5 of them, we were able to generate the report. We were able to get a tumor board together. An individualized treatment plan was actually produced. Because this was not a treatment study, the information was given to families, but they did not have to accept that information. All of this was done in less than or equal to 12 days, so we did feel that we could do this in a reasonable amount of time. And in fact, we were able to get tissues growing in the lab to also be able to analyze those as well. So the current study, which actually opened at the beginning of this month, is a feasibility trial using molecular-guided therapy for treatment of patients with refractory and recurrent neuroblastoma. The difference here is that this will actually be a study to try to isolate whether or not these therapies are working. So families who come for trial on this trial, the treatment plan will be offered to them, and we will continue to follow what happens for those children after they enroll in study, if they choose to. The tumor board itself is including not only the information about the report that was given to us, they have all the information on the previous therapies. So though a drug may show up high on the list, if it's something they've seen a lot of in the past, we know that it may not be that effective, or else it may not be effective in the combination it was used in before. In addition to that, all of their socioeconomic status questions concerns, all of that is brought into the tumor board and taken into account when coming up with trials with the actual therapy. So whether patients want primarily outpatient therapy, something relatively easy to tolerate, whether they need to travel a lot, all of that will be taken into account so that we can try to come up with truly a personalized therapy for that particular patient. This takes a huge number of people, and this is the clinical teams and science teams that are actually working on this. The bioinformatics team, which is the group that is really running all of the computer work, understanding the connectivity between different systems. They have, as I said, several programs already assessed and have been doing this in the adult world for the last almost 5 years now, and we've been working with them since then. It's the clinical team of people who will be part of our tumor boards, and eventually all the sites that will have this open are listed below. The FDA did give us license to move this trial forward. They wanted us to start off in a small group, so they said open it at 5 of your institutions first, and after you've gotten the process started, then move it to other institutions. So the 5 institutions that have it open currently are listed here. And then contact information, if anyone's interested in this trial, it is actually on the government website for clinical trials, and we have a number of people that can be contacted in order to be part of these trials. Actually want to thank all of the people who have helped sponsor our trials. Most of our trials have actually been sponsored by parent and family groups, and they're all listed up here. The only industry trial that we have is from Archer. That's the company that actually makes TPI 287, and so they do provide the drug for free. But most of the money for our trials has come from families, and this has been an amazing journey so far. And last but not least, all the different centers that have a particular trial open. The NCI is participating in our personalized medicine trial. They're not actually part of the NMTRC, but they are for this particular trial, so I've listed them as well. And that's it.
Thank you, Dr. Eslin.
Your science is excellent. Y'all are to be commended. That's way over my head, but I can just tell there was a lot of work that went into that.
Thank you. It's over my head, too, for some of it.
I feel pretty dumb standing up here, but I had a couple of questions about the personalized medicine trial.
Yes.
I guess the first one is who or how was the database constructed that classified those commonly approved drugs by genetic target? Because that's probably the horsepower behind that.
It is.
Yeah.
So there are actually 4 different databases that have been put together over somewhere the last 4 to 6 years that are now publicly available. Those databases actually include most of the information that shows up in scientific papers that all the different people in clinical areas write papers about. So it's a huge group of people that have pulled that together. We're able to access that now because it is commercially available. So Craig Webb, who, I go back up 2. Craig Webb at the Van Andel Institute, this has been his purpose in life for the last 10 years. He's been pulling these databases together. He's a PhD scientist, and that's what he does. He finds the data and puts it in the proper place. The databases are actually updated all the time as well in order to add all the new information that keeps coming out about the interactions between drugs, molecules, hormones, all sorts of things. And there are a lot of things that show up on our lists that we would not have thought of before.
Yeah. And just 2 smaller questions. The tumor board, do y'all come up with a cocktail of drugs or just one? And what about, and how do you arrive at the dosing?
Good question. So, and that's the purpose of having multiple specialists at various institutions on the tumor board. So we also invite the primary physician of the patient to be available as well. And there is a pharmacist on the tumor board itself. So the drugs themselves, it's relatively easy actually to start looking at the list, looking at what the patients had in the past, and then finding out, what sort of mechanism, what the patient and family would want as far as what types of treatments they would like to do. So that's the first step. Once we get it narrowed down to a few drugs, then we start looking at, okay, what drugs are known to interact together well or badly. And so both of that scenarios are looked at. Our PharmD actually is able to pull up, again, through several websites, information about the drugs, both in dosing mechanisms, interaction mechanisms right away, so that we have the information at our fingertips when we try to do the tumor boards. The internet now has made things so much easier for accessing all of this stuff. So all of us are sitting actually at a computer looking at both the list and the databases while we're talking about it. The tumor boards are actually done by phone conference across the country.
I've got a couple of questions.
Yes.
I'd like to start with the TPI-287 trial. I missed the preclinical data showing that you're getting an interaction between that taxane derivative and temozolomide, irinotecan, and xenografts. Did you have it?
Yeah, we did. I didn't put it up because, again, there was just very limited time.
There's a substantial amount of data correlating xenograph responses to irinotecan, temozolomide with what we see in the patients. So what happens when you add the TPI-287 on top of that? It is improved. Not a whole lot. Can you show us the data?
I don't have it, actually. I'm sorry. Dr. Scholler has that information. I don't think it's not a whole lot more than TPI plus temozolomide alone.
And the second question is that I'm sure you're aware of the numerous reports on pediatric problems with the Cremophore formulation and the toxicity thereof. Are you concerned with going directly in with that, with you have no data with a single agent and understanding of what the toxicities might be?
So the Cremophore issue was a big issue for the phase 1 study, but we've actually finished that, and now there were 15 patients on the study, and we did not see significant problems with the Cremophore. The good thing about that now for the next studies is that the Cremophore dosing is going to be drastically reduced. It was a 50-50 Cremophore plus alcohol in the first study. It's now going to only be 15% Cremophore in the new dosing of the TPI.
Okay. On the personalized medicine trial, now I want to get this straight. You're biopsying patients specifically to do an analysis of them by some microarray technology.
Correct.
Okay. And which microarrays are you using?
It's not going to come. The messenger RNA.
Well, is it Affymetrix 133s?
Yes.
Is it exon arrays? Is it Agilence? Which is it?
It's the Exelon.
It's exon arrays?
I think it's Exelon. Yeah.
Okay. Is there any data at all that you can tell us about that validates that the use of any of those microarrays predicts effectively a chemotherapy response?
The Van Andel Institute did a 50-patient study that's actually been published already that included both pediatrics and adult patients using the same methodology that we're using now. On that particular study, 2 of the 10 children who were on the study, 1 neuroblastoma patient, 1 leukemia patient, were treated with the therapies that were recommended. Both had responses. The leukemia patient actually went into remission and was able to go to bone marrow transplant. Of the adult patients, only a few of them actually had significant responses.
Okay, you're talking about, this is an ALL patient, I presume?
Yes.
And if you take a first, second, or third relapse ALL patient and treat them with vincristine, prednisone, L-asparagine, what's the probability of getting a response in any patient?
Correct.
40% of them will go on a CR.
But this actually used a drug that no one had used before.
Right, but you could probably use dose escalation of Kool-Aid in some ALL patients to get a response. Okay,
yes.
They really do frequently get responses. So I don't think that's data that tells us that this is going to benefit a patient. Would you agree? Is that your data that you're citing is not telling us that you can say with reasonable certainty that what you're doing is going to benefit the child that's going on the study.
Correct.
So, with that in mind, given the principles of the Helsinki Convention and the OHRP regulations that state that in order to offer an investigation to a child that has greater than minimal risk, and I think we will all agree that a surgical procedure under general anesthesia falls in the category that every IRB would say is greater than minimal risk. How is it that you can...
Sorry, the procedures are actually needle biopsies only.
They're needle biopsies only.
Or bone marrows if the patient does not have a solid tumor.
And you feel that you're... and how are you quality controlling for a needle biopsy? How can you do a pilot section on a needle biopsy to know what the tumor content is before you do a microarray analysis on it? The TCGA would never do that.
I'm not quite sure.
All of the needle biopsies have touch preps made, and a pathologist looks at it before we send it to the CLIO certified lab.
Okay. Pat, because we've got a couple of other questions, so...
Okay.
Okay, thank you. Jason? Or Mr. Howell?
Well, first, you, the name of your organization is a Translational Research Consortium for Neuroblastoma and Medulloblastoma. I take it that you see a connection between those two different cancers?
They have some similarities, and some of the treatments are very similar. So it's more because adding another cancer type allows for more children to be benefiting from experimental therapies, and as long as there appears to be data that both of the tumor types are responsive, then we've been using those.
And on the genomic work that you're doing, did I understand correctly that you're able to get an adequate sample from a bone marrow biopsy?
For the bone marrow biopsy, aspirations and biopsies,
Right.
If patients have significant amount of tumor in the bone marrow, they have to have 70% or more in the sample that's collected to be eligible for the study.
Okay. And you indicated in an oral remark that there were sometimes differences in the bone marrow genomic analysis when you had an adequate sample and a tumor analysis. Is there a reason for that?
Yes. Short answer, yes. Neuroblastomas appear to be very heterogeneous, very different, even within one person. So it's very probable that the tumor cells that have left a primary tumor site and traveled elsewhere now have some differences in them compared to the original tumor that stayed in a mass.
And then in terms of your analysis of the genomic structure of in terms of the work you do, does that also tell you whether or not drug resistance is developed to the drug that's indicated as a possible treatment?
I'm not sure I understood that. Can you repeat that one?
If your analysis shows that an irinotecan is an appropriate drug,
okay,
does it tell you whether the patient is already resistant to irinotecan?
No, it doesn't.
That's all I have. Thank you.
Jason?
Hi. Jason Cho at Baylor. I'm at Baylor College of Medicine. I just have a comment and a couple of questions about the personalized medicine approach that you guys are taking. So, doing expression profiling on biopsy specimens is fraught with difficulties to begin with. And then doing in 2000, I talked with Javed and Jeff when they were first designing that trial, 5 years ago. In 2011, microarray analysis for gene expression profiling is more or less obsolete, and it doesn't take into account microRNA expression or siRNA expression or everything that we're learning about metabolic processing in tumors. I understand that Jeff and Craig at the VARI have supercomputers and are looking at a lot of meta-analysis, a lot of data, but in the end, in the final analysis, What goes on at the tumor board discussion that doesn't go on with a one-on-one discussion of a physician and a family facing relapsed neuroblastoma that is going to add additional therapeutic importance? I mean, it just seems like you're using like last century technology and a oversimplified analysis of the whole process. It doesn't seem personalized to me. So,
it is a good question. As far as the methodologies, they're moving faster than really we can keep up with. But we had to pick a method to start with, and in fact, we are behind the scenes trying to do some of the other methodologies. They take longer, which is a big problem for some of the other methodologies. So they are, and 10 years ago, even this took too long. So we've picked what we can do in a feasible time frame to move it forward, but also in the background, we are going to be also testing the samples against other methods and actually reconvening the tumor board after a month and find out whether or not, both from patient data as far as how they have done and secondary methodologies, whether we still have accurate information. That's one part of it. As far as the difference between just sitting down and talking to a family, you're right. What is the difference? The difference is right now when we sit and talk with families about relapse disease, we go through some algorithm, and it's different for each particular person or institution depending on what your experiences are. We're using information that's from previous trials to talk to families about what might work, what might not work. In this setting, we're at least adding one more piece of information as far as from that particular tumor, what might work, what might not work. So if we had evidence that methotrexate might be of benefit, that's not something we would normally think of, so we might add it. Whereas if the cyclophosphamide showed to be a very poor drug, then we would quickly discount that. Whereas for relapsed patients, someone might try and say, okay, well, topocyclo has been a commonly used therapy, we can try that one again. So we're adding only one more level into what would normally be done for patients with relapsed disease.
Thank you.
Didn't Sloan Kettering do a big study on the various FDA-approved medications out there or chemotherapies? Because I thought they were involved in a huge study involving, testing and looking at various responses from various different drugs and chemotherapy agents.
I'm not actually sure.
Okay. Yeah, I thought they had.
No, I have.